Good afternoon, everyone. On the afternoon of Friday, July 30th, 2021, I stood outside the emergency room entrance of UT Southwestern Medical Center in Dallas, Texas. I'd been there for a few hours, not an unexpected amount of time to spend at the ER, while my sister and I waited with our mother for a visit from her surgeon. A year earlier, she'd had a bilateral mastectomy performed at the height of the COVID-19 pandemic and nearly 19 years after her first breast cancer diagnosis. Our visit to the ER in 2021 was about 8 weeks after a second 8-hour surgery that was the direct result of the prior year's mastectomy, this time for a quick check to examine a troublesome incision. Mom's surgeon released her with instructions to come back the following Monday for a surgical cleanse, and I set off to retrieve the car. As I stood waiting for the car to arrive, $5 valet parking for patients is a nice side benefit in a state with so much land available for parking garages. The valet attendant started chatting with me. After a few innocuous comments, he suddenly asked, "Did you take the COVID vaccine?" I replied, "Yes, absolutely, and so did all of my family members." And so began a fascinating conversation that included tales of government conspiracies and plots to track citizens based on devices included in the vaccine, and even a connection to monkeypox. I decided not to tell him that if he was worried about being tracked by the government, he should put down his cell phone. At one point, the attendant posed a question that he undoubtedly thought would carry weight with me. "Answer me this," he asked. "How did they manage to develop a vaccine so fast?" My response, because practically the entire biomedical world, from academic labs to multinational pharmaceutical companies, started working on it. Imagine the global problems we could solve if only we worked together to do it. My name is Crystala Jones-Prather. I'm the Arthur D. Little Professor and Department Head of Chemical Engineering here at MIT. And I am also a class of 1994 undergraduate alumna. In my time as a student and a faculty member, I have come to see that MIT is an institution that is collaborative by design, with our infinite corridor representing endless possibilities, and our connected buildings and hallways serving as a physical reminder of the lack of true boundaries between our disciplines. After all, the beneficiaries of our scientific and technological advancements, including my mother, who participated in a clinical trial after her initial cancer diagnosis in 2001, that I learned 15 years later established the standard of care for adjuvant hormonal therapy. These patients are not concerned with the fields of study or the affiliations of the inventors. And so as we launch the MIT HEALS Collaborative, we do so with the intention of tackling big problems by asking, what if? And working together across boundaries and barriers and even institutions to find the answers and deliver solutions. What if detection of diseases like breast cancer could be made easier, less invasive, more accessible, and more comprehensive? Could this lead to earlier detection, better health outcomes, and greater patient survival? What if we really work to understand the unique dimensions of women's health, with women being disproportionately affected by autoimmune and chronic inflammatory diseases? Could we see new human tissue models giving way to novel physiological insights and new paths for effective treatments? What if we tackled ovarian cancer in a fundamentally new way, fusing knowledge gained from basic immunological sciences with novel engineering approaches to delivering immunotherapies? Could we leverage the partnerships of academics and clinicians to change the outlook on this disease? What if we thought about education in a radically different way by working not just in research labs, but also in the communities where epidemics take hold? Could we incorporate the social scientists to foster a deeper understanding of the challenges associated with the adoption of new medicines and develop new approaches to more deeply understand the many dimensions of health? In this session, you'll hear from 4 of my amazing colleagues, each of whom is using interdisciplinary approaches and collaborative partnerships to ask and answer these questions. As you listen to them, I hope you're inspired to think about the possibilities, the promise, and the hope that their work represents, to reflect on the patients, perhaps some well known to you and others who may remain nameless, that would benefit from the achievements yet to come, and to consider if and how you can contribute to these missions. Oh, and yes, my mother is continuing to live her best life, having spent Thanksgiving week traveling in Australia, thanks in no small part to a continuous community of scientists, physicians, and engineers who never stop asking, what if?
Nobody knows your body like you do. Imagine spotting dangerous diseases way before symptoms arrive. Protecting yourself by detecting yourself is the goal.
So this wearable non-invasive ultrasound patch is specifically for early breast cancer detection.
Professor Dak DeVaron has been working with her students for 6 years on a wearable breast monitor. Because it uses ultrasound waves instead of radiation to create an image, the monitor can be used regularly. This invention inspired her students to create smaller, even less invasive silicone patches that can scan for other cancers.
Wearable technologies will grow rapidly in near future, but in the far future, they will be one of the most powerful tools that we will be seeing in our daily life. So we create that far future right here at the MIT Media Lab by blending media, arts, and sciences. Specifically for my group, we are focusing on women's health, and we create technologies for female technologies, which I often call femtech. And let me tell you why by giving 3 dramatic facts. 80% of autoimmune diseases are in women, and we still don't understand why. Heart disease remains the #1 cause of death in both genders, yet women wait more in ER to be treated. Women were excluded from clinical trials until 1993. Hormones were given as an excuse, and which means there is a massive data gap in hormone health. And since mice don't menstruate, how can we catch up? To catch it up, in my group at the MIT Media Lab, we create devices which are organ-specific. These devices can be thinner than your hair fiber and implantable like a needle, can go in the deep brain and do neurological explorations and stimulus. And at the same time, these devices can be directly worn on your largest organ, skin, to do hormonal drug delivery all the way from face to the abdominal skin throughout the IVF process. Or these devices can be attachable to your personal garments, like your daily bra or underwear, and they can detect your breast cancer at an early stage and or monitor your bladder volume to better understand your kidney health and wellness. Let me give you an example more in depth. It's a wearable ultrasound breast patch for early breast cancer detection. It's a technology that was invented here at MIT, and this device is non-invasive and can be directly placed in the internal wall of your bra. By using safe, non-radiative ultrasound technology, this device can detect any anomalies within sub-seconds, literally by you are sitting on your seats and listening to this presentation. And this data is sent to your medical doctors, and your medical doctors can tell if you are supposed to come for more sophisticated treatments or screening at the hospital. This is specifically important for the women who have barriers to this kind of technologies in the rural areas, and also for women who are on high risk and needs to do periodic screening to increase their survival rate to up to 98%. And this is also important because high-risk women often diagnose between 2 mammographies and decrease their survival rate up to 22%. So with our technology, what we are trying to do, not only doing the science, also creating stories behind that. I'm not only doing science at MIT, it's a calling for me, and it has a personal story. I lost my aunt at the age of 49 and a half years old. In this picture, she's Fatma. She's very happy, very beautiful, and holds tons of hopes for future. Whereas in this picture, she's only 49 and a half, sick, tired, and in pain. The entire process was miserable, not only for her, for all of us around her. Despite the fact that she had regular breast screening, she was diagnosed with breast cancer and could survive only 6 months after this picture was taken. So like my aunt, many women suffer from this devastating disease. And the breast cancer is the #1 cancer type among women, and even the number is higher than the combination of other leading cancer types. And more dramatically, every 8 women, 1 will be diagnosed with breast cancer during their lifespan. And the current standard screening tool is mammography. It's painful and it's radiative, so you can't do it periodically. You can't screen your breast tissue. And by the time you have your second mammography, by assuming the first one is clear, 40% of high-risk women develop interval cancer in between, with the survival rate of 22%. Imagine a world in which your daily bra will allow you to check your breast tissue regularly to increase your survival rate up to 98%. That world is right here at MIT. This is our product, our technology. It's a daily bra that you wear with a wearable ultrasound technology inside, which can capture the data within sub-seconds with no skill operator needed. And this data is sent to the cloud and collect the data. And by using AI and machine learning, your radiologist and doctor can have an AI-supported report. This is important because current ultrasonography technologies are handheld. You need an operator, you have to go to doctor. And oftentimes, as you can see in the picture, they are bulky. They have to press, the doctors need to press against your very personal part of yourself. And you need to use a message gel, you need to clean off afterwards, time consuming, it cannot offer frequent visiting, and it's expensive. Whereas in our technology, 1 scan will cost less than a cup of coffee. And how it works, anyhow, it doesn't go, but anyhow, we use inflexible cables which can come all together and print on a biocompatible substrates, which can go internally your bra and scan the tissue up to 260-degree angle with 12 centimeter information. Why it matters? Because our technology can provide a resolution up to 0.02 centimeter, which is an order of magnitude smaller than the stage 1 tumor sizes. With frequent screening, we can enable early breast cancer detection. It matters because just in US, we have 44,000 women lost their life because of this disease. And the breast screening is $30 billion and it's increasing 30% every single year. With our technology, we can increase the survival rate up to 100% by decreasing the medical cost by half. So this was a dream on a piece of paper that I drew on the bedside of my aunt just to relax her. And even while she was in pain, she was giving me feedback. Now it's real, and I can touch people's bodies, skins, breasts, and their lives all together with my amazing students at MIT Media Lab. Thank you.
Good afternoon, it's great to be here. I'm Linda Griffith from Biological Engineering, and I direct the Center for Gynepathology Research here at MIT. What I want to tell you about today is a new movement that we're starting at MIT. It's called the Move Over Mice movement. And what inspired it is the incredible challenges we have creating effective therapies for diseases that preferentially afflict women. Now, they'll help everybody, but they are motivated by helping women. Now, why do we want to move over the mice? Well, you know, think back before COVID, we had colds, we had the flu, and then we had that very special disease, the man flu. And you know what I'm talking about. Husband, wife get a cold. The husband's in bed dying while the wife's taking the kids to soccer. Okay, everybody knows that story. And if you look at the X and Y chromosome, it's not surprising. So many things missing from the Y, including some immune genes. Okay, now, so it's biologically true that men will get sick. This is proven. They'll get more acutely sick. But women stay sick longer and they develop more chronic autoimmune and chronic inflammatory diseases. They're the result of multiple gene-environment interactions in humans, very, very difficult to study in mice, and that have provocative links to the way we reproduce and menstruation. And so we can't really hope to make a lot of progress if we continue to study animals. We really need to study the patients and replace our animals with living patient avatars and studies on patients. Now, I'm going to tell one story to illustrate the move over mice principles. About 15 years ago, we started working in a chronic systemic inflammatory disease called endometriosis. And probably most people have heard of this, but it's when you find bits of tissue similar to the uterine lining, the endometrium, growing other places like the abdominal wall, invading into the bowel. It can invade through the diaphragm and get to the lungs and so on and so on. It's incredibly debilitating, causes pain, infertility, vomiting, systemic sickness. And we don't know what causes it, but we do know about 10% of women after the age of 12 or so will have this disease, and it's very hard to diagnose. Now, I wouldn't be here talking to you today if we had good treatments for it. Some patients respond to birth control pills or menopause drugs, but a lot of them have repeated surgeries. Now, I got involved in this when a local surgeon, Keith Isaacson, who's a fantastic surgeon and clinician, called me one day and said, I operated on a 23-year-old woman. It was her 10th surgery for endometriosis, and she got operated on in that OR there on the right at Newton Wellesley, where we now collect patient samples, because I got together a group of people and we started to study endometriosis. Okay, so what do we do? Well, we're not the kind of engineers who make devices or surgical tools. We're biological engineers. We study how systems work. So we reasoned that we could maybe start to classify patients by studying their immune networks in the peritoneal fluid. So we studied about 100 patients, did some targeted proteomics, and we were able to identify in about a third of the patients a particular inflammatory network associated with an intracellular enzyme in immune cells called Jun kinase, okay? And so Jun kinase, this is very exciting. Maybe if we inhibit it, we could have a new non-hormonal drug target. And so turns out we go and find out that there was find these two papers, that there was a drug company, Merck Serono, that had been developing Jun kinase inhibitors for other diseases, and one of their amazing scientists, Steve Palmer, convinced them to do preclinical models of endometriosis, and that their drug worked there. Unfortunately, it didn't work when they licensed it out and they went into clinical trials. It didn't have the right potency or patient heterogeneity, whatever. But the Steve Palmer there turns out to stay involved in the field. So I got invited to give a keynote talk at the American Society for Reproductive Medicine meeting in Hawaii. In 2014, there was a hurricane, over a foot of rain that weekend. And who did I run into but Steve Palmer? So we sat inside and we talked about the future of endometriosis drugs. And he said, I'm leaving Merck, I'm going into academia, I'm going to develop new drugs, but what we need to get into the clinic is we need human efficacy models. We need the patient on a chip, we need a lesion connected to blood vessels, circulating immune cells and all of that, so you go do that. Well then, okay. So the first thing we had to do, we had plenty of access to patient biopsies, and other people in the field had figured out how do you make organoids from these patient biopsies. You can see the glands from the endometrium on the left. But what they were doing is using some terrible reagents to make 3D cultures of these. They had something derived from a mouse tumor to make the 3D environment. It degraded. It was really not great for the biology. So we used our polymer science and biological engineering skills to design a completely synthetic hydrogel to support all the different cell types in a lesion. So you see here the beautiful epithelial organoid, blue with green in the middle, and the red cells are the supporting fibroblasts growing in this gel. And labs around the world have used this, and it's now being commercialized. But of course, the lesion has to be in contact with blood vessels, and we were fortunate that our colleague Roger Kam had invented a way to grow a vascular bed in between two microfluidic channels, as shown here. And our student, and the movie's not playing, but if it were playing, why is it not playing? Our student, Ellen Kahn, had shown how to flow immune cells through that vascular bed from one side to the other. But what we had to do was adapt this to accommodate endometriosis lesions. And so what we did is design a new chip, bigger, with pumps, and we put the vascular cells and the lesions together, and what you see over a 6-day time lapse here, you can see the lesions, they're in the green boxes growing, and you can see the blood vessels forming from the vascular cells to build a network of blood vessels around them, and there's immune cells in there also. Okay, so now we're ready to go. We did our part. What did Steve Palmer do? He went to Baylor, Drug Discovery Institute, developed a whole new set of Jun kinase inhibitors with NIH funding, and then he licensed them to a company called Cellmatics. He left Baylor, he's now at Cellmatics, and here we are a few weeks ago starting the launch of a project so that we will do preclinical efficacy testing with the Cellmatics team, Steve Palmer and the CEO, Pariah Baim, and the MIT team. Of course, Laura Ballman actually does all the work. She's a postdoc in the lab. But this EndoChip, you know, there's still a lot of things evolving about how regulatory agencies view this kind of efficacy data. So there's great conversation going on, but no matter what, you have to prove your drugs are safe. And so we come into this project with decades of experience working with drug companies on building these kind of patient avatars for drug safety, particularly liver. So I invented something called the liver chip. It's widely used. Novo Nordisk has built a lab close to MIT to interact with our team on how to use this 3D liver model of human liver for cardiometabolic disease. We've done interacting organ systems as shown on the right, and smaller versions of them are commercially available. So we know we have to get these out into the wild in collaboration with lots and lots of users, and we have to also build many other organ systems similar to what we have for the EndoChip and connect them together. So our vision, and it's under construction, is a living patient avatar core facility at MIT, and Kelly Pate, the head of the Division of Comparative Medicine, is very on board with this because she would like to move some of MIT's mice over. In order to do this, we had to develop a whole new platform technology. What I showed you on the previous slide is about 10 years old. So together with Dave Trumper, in partnership with Novo Nordisk and a lot of other partners, we're developing all of these for pain, for liver, for chronic infection like Lyme disease, gut microbiome. And these are real things that we want to have on campus for people to be able to use. So I'll close there and invite you to come to the poster session if you want to hear more about this and other diseases we study. I encourage you to join the MIT Move Over Mice movement, and be happy to talk to you about it later today. Thank you.
Good afternoon, everyone. So I am a chemical engineer who works in biology, and I'm going to be talking about how we can use extremely small layers to address cancer. In our work, we actually use alternation of positive and negative charge to build up extremely thin nanoscale films. And in this work, we've been studying how we could take an existing small drug nanoparticle, like a liposome or a polymeric particle, maybe it has a net negative charge, and wrap positive and negatively charged layers. In this way, we can actually incorporate a chemotherapy drug in the core and wrap around this nanoparticle other agents. For example, after a positively charged layer, we can put something negatively charged like siRNA that can silence a gene that enables the cancer cells to survive that chemotherapy drug, thus creating a way to address chemoresistance. And one of the most important parts of these layers is that final layer, negatively charged, that enables us to have a nanoparticle that doesn't engage with other cells, but might be designed to engage specifically with cancer cells. So, you know, these are squishy materials. I'm a polymer materials scientist, and we enjoy making these systems. But the idea is that we can actually coat them in a way that allows us to direct therapeutics specifically to cancer cells in chemotherapy. And I like to compare this to a Wonka gobstopper for anyone who remembers what those things are, that have layers of candy that dissolve at different times, which gives us a chance to regulate how the drug is introduced. However, when we became really interested in addressing ovarian cancer, we found that this approach was not necessarily the best approach using siRNA. Ovarian cancer has been a very difficult cancer to address. It affects a large number of women and is detected late stage because of the very subtle symptoms that it provides us. For that reason, although a large number of patients are able to recover after the first chemotherapy treatment, about 80 to 85% of them will suffer a recurrence, and that recurrence will be a highly resistant form of the cancer. For that reason, it would be really interesting to have an immunotherapy that would allow this cancer to be attacked by the human immune system when it comes back. Unfortunately, there's been little progress in doing this because there are not a large number of immune cells that reside in ovarian cancers. So when we began looking at this problem, we started thinking about making a nanoparticle that would be extremely sticky to ovarian cancer cells, but not to other cells. And we did this by looking at a library in which we started with the liposome and wrapped positive charge, and then a range of different negatively charged stealth layers, polysaccharides, polypeptides, and a range of other biomacromolecules that might be able to help us with targeting as well as with getting through the ovarian space, this intraperitoneal space. And in doing so, we found that there were a few that were very interesting to us, and those few actually showed a very high affinity for ovarian cancer, whether it appeared in the primary tumor, here we see a tumor lit up, and the infrared particle showing up in a very nice overlay, but also in metastases within that intraperitoneal or abdominal space, like this gut system. Now, we found that there were two that were really interesting to us. One of them, hyaluronic acid, actually binds to cancer cells and gets taken up into the interior and releases things like siRNA and chemotherapy drugs. That's really interesting. But we found another one of them, poly-L-glutamic acid, a very simple polymer that causes the nanoparticle to stick on the outside of the ovarian cancer cell. Not great for delivering siRNA, which has to act on the inside. However, it does allow us to present something to neighboring cells. And we began to think about how we might be able to use this. I began to talk to my downstairs neighbor at the Koch Institute, Daryl Irvin, who knows everything about immunology and cancer. And he was able to inform about how we might be able to use this to deliver a cytokine known as interleukin 12. IL-12 actually can induce large amounts of infiltration of immune cells, in particular T cells and NK cells that are responsible for killing cancer. So we decided to then take our liposome, attach that IL-12 to the liposome directly, wrap it in plus charge and then minus charge, and that minus charge will take us to the ovarian cancer cell. Deliver this into the intraperitoneal cavity and let this get presented to neighboring cells, which will eventually lead to the generation of interferons and the infiltration of T cells. And we did indeed find that we had enriched T cell infiltration in these layer-by-layer nanoparticle systems. In fact, when we looked in a mouse ovarian cancer model, we found that there were something like 10,000 or more infiltrated T cells compared to untreated mice. And what was really exciting is that we found we could combine this IL-12 treatment with checkpoint inhibitors. Now, it's worth mentioning that the reason IL-12 isn't used in the clinic today is because it is extremely toxic. It can also excite the immune system in the bloodstream. In our work, attaching it to a nanoparticle that is very specific to the cancer allows us to rescue that toxicity and avoid any kind of side effect. Checkpoint inhibitors are typically not effective in ovarian cancer at all. So what we did was we combined IL-12 with a checkpoint inhibitor. And in this case, we changed the immune microenvironment. So now there are immune cells that can be impacted by the checkpoint inhibitor. And what we found remarkably was in this red line, as you see here, 100% of the treated mice survived. Compared to all of the other treatments, checkpoint inhibitor, which does barely nothing, and any of the other IL-12 combinations that we looked at. So we're very excited about this work and looking at how we can take this on to clinic. Now, I mentioned that little story about getting inside the cell. With other collaborators, Joan Brugge, who is at Harvard Medical, and Ursula Machulonis at Dana-Farber, we've been looking at how we can encapsulate inhibitor molecules. Again, so toxic that although they are together very effective against ovarian cancer, they're also very effective at harming the liver. And in this case, we encapsulated these in a polymeric nanoparticle and used our hyaluronic acid targeting system to get this directly inside ovarian cancer cells. And again, we saw a great deal of improvement in ovarian cancer treatment. So this theme of the collaboration is really important to us. I usually show a slide of all of the students involved, and we have some incredible students and postdocs involved in this work. But I wanted to point out collaborators who have impacted us in our journey to address ovarian cancer. I mentioned Daryl Irvin, my wonderful neighbor who has informed us about every aspect of the design of these systems, and we have worked together to develop it. But we also have had this wonderful collaboration with Harvard Medical School and Dana-Farber. We're involved in Breakthrough Cancer, which brings us together with one of our younger colleagues at the Koch Institute, Stephanie Sprainer, also an expert in immunology and tumor biology, and Saurabh Shah at Memorial Sloan Kettering, who is looking at patient cells that are being treated and determining changes in the genetic signatures of those cells before and after chemotherapy. If we can understand what the outside markers of those cells are, we can find nanoparticles that can then be targeted directly to minimal residual disease and treat them and excite the immune response in them using the studies that Stephanie is doing. And finally, we have a wonderful collaboration with my MIT colleagues and colleagues at Johns Hopkins with Angela Belcher, Sangeeta Bhatia, Kripa Varanasi, and Rebecca Stone at Johns Hopkins. And in this case, we're reaching much earlier. Intervention is really critical. Ovarian cancer tends to be detected at very late stages. Angie has developed nanoparticles that are able to allow us to see inside deep tissue. And we are using our sticky nanoparticles to address being able to detect those tumors and even early tumors that appear on the fallopian tube. So with that, thank you, and we're really excited about collaboration, and I think that this new initiative is going to allow even more of these opportunities to take place.
Hello, my name is Bruce Walker. I'm a physician scientist. I've spent my career taking care of patients and studying HIV. And it's my great pleasure to tell you about a course that I teach to MIT undergraduates. Each January in the intersession, we select 20 students from all majors and take them to experience an ongoing epidemic to understand the many dimensions of an epidemic. We go to South Africa. You can see from this slide the staggering prevalence of HIV infection there in the areas that we work. 40% of men and 62% of women in the ages 25 to 44 are infected and will need lifelong therapy. It's in that context that the students get to see what it's fueling that epidemic. We land first in Johannesburg, where we begin the didactic portion of the course. We incorporate a number of African students with the MIT students, and we begin to teach them where HIV came from, how it causes disease, how the body fights back, and how therapies are developed, and why 4.5 decades after discovery of HIV, there's still no vaccine. But we don't stop there. We also teach them about how policy and advocacy influence the course of an epidemic. Here they're learning from Edwin Cameron, who was the Chief Justice of the South African Supreme Court, who presided over the trial that led to the force the South African government to provide treatment to its citizens. He's also a gay man, and he tells the students about the problems of stigma and discrimination that he himself encountered and that are so widespread in that population. We then go to Durban, where we had participated in collaborative research for 25 years with African scientists. We helped catalyze the construction of 2 research institutes there by funneling money from the United States to support that construction. The students get a chance to see African scientists and talk to them about the opportunities and challenges of doing research there, but they also get a chance to see ongoing projects that are underway. One of those projects is called FRESH, probably the most exciting project I've ever worked on as a scientist. Stands for Females Rising Through Education, Support, and Health. And it has 2 goals. One is it's an HIV prevention program and poverty reduction program geared at young, high-risk women, 18 to 23 years old, who are living in poverty and because of that are at high risk for HIV infection. But it's also a study of acute HIV infection. And essentially, we see the women twice a week for 9 months, teach them empowerment, life skills, job readiness training, and each time they come in, we do a fingerstick blood draw to identify anybody who, despite our efforts to prevent infection, has become infected. The students get a chance to talk to these women and understand what it is that's fueling the 10% per year incidence rate of new HIV infection in that population. They also get a chance to see the part of the empowerment program, which is teaching these women, most of whom have never graduated from high school, teaching them how to use a computer. Most of them have never touched a computer before. We conduct the study at a shopping mall to avoid stigma that would be associated with coming to a clinic or to a hospital. And the course really completely changes the lives of these young women. They come in with no real sense of hope about the future, and they leave having found their voices and feeling like they really can make a difference. Of the 3,000 or more women that have gone through this course, 80% of them we've been able to get employed. The unemployment rate is so high that these women would really never have had an opportunity to become employed, which moves them out of poverty and reduces their risk of HIV infection. We also take the students to local hospitals to understand delivery of care in a resource-constrained setting. Here talking to a young man who's infected not just with HIV but also with TB, and the challenges in a resource-constrained setting of delivering care with a highly contagious disease like tuberculosis. We go deeper into the rural areas of KwaZulu-Natal to teach them about delivery of healthcare there. This is a pharmacy, and out on the table you see traditional medicines. 80% of South Africans will go to see a traditional healer before they go to see Western medicine. We've been collaborating with traditional healers for the past 7 years, and through a process of building mutual trust and respect, we've been able to implement with them an HIV counseling and testing program so that when they see patients, they now not just rely on their traditional medicines, but they test them for HIV and refer them to us if they need therapy. So the students see those traditional healers and hear from them how they were called to that profession. We also introduce them to infected mothers and their infected babies so that they can understand how those mothers became infected, what the factors were that led to that, and understand how difficult it is to raise a child who's HIV infected. We also go deep into the rural areas of KwaZulu-Natal. Here are some of the students with a mobile clinic. This is a catchment area where the Africa Health Research Institute has been collecting data on the whole population of about 160,000 patients once a year on every person in that region. And the students go and make house calls with the RE investigators, and then come back to the Research Institute and use that data to answer questions that they have generated through the research through the visits that they've made. At that point, we're so far north in KwaZulu-Natal that there are no local hotels to stay in. So we take advantage of that and take them to a game park where there is a hotel. And there they do problem sets in traditional MIT fashion, comparing and contrasting different epidemics, et cetera. And they then present those data to one another as a sort of a wrap-up. In between the problem sets, they go on game drives to see another dimension of the African landscape. And finally, when we get back to Durban, to the airport, to head back home, I think it's fair to say that their lives have really been changed by the experience. They realize that epidemics are multifactorial. They're not just the realm of medical doctors and scientists, but really every discipline has something to offer to help come to a solution. They also learn that it's really important to learn from the patients themselves and to understand what the barriers are to care that prevent some of the things that we develop from ever being actually utilized. And what I learn year after year from teaching this course is that MIT students are incredibly motivated, incredibly bright, and incredibly passionate about making a difference in the world. And I think we as educators have to show them those worlds and facilitate their involvement in that. I'd like to finish just by acknowledging Misty and IMES and the Reagan Institute for their support, as well as philanthropic support. We set up this course specifically so that it would not cost any of the students any funds of their own, because we didn't want economic considerations to prevent anybody from taking the course. And so I thank you for listening.